Thyroid storm management. Thyroid storm represents a life-threatening endocrine emergency that mandates immediate and aggressive intervention. It is a state of severe thyrotoxicosis, leading to systemic decompensation. Our primary treatment goals are multifaceted and must be addressed urgently. We aim to reverse the systemic effects of the crisis, to block the actions of thyroid hormones at the peripheral tissue level, and to inhibit the synthesis, secretion, and release of additional hormones into the circulation. Timely initiation of therapy is essential for patient survival. Pharmacologic strategies. Management of thyroid storm relies on the simultaneous application of several classes of medications to interrupt the pathology at multiple points. The first-line approach involves antithyroid drugs. Propylthiouracil, or PTU, is administered with an initial oral loading dose of 500 to 1,000 milligrams, followed by a maintenance dose of 250 milligrams every 4 hours. Alternatively, methimazole, or MMI, can be given orally at 60 to 80 milligrams per day or 30 milligrams per day intravenously. The role of these drugs is to block new hormone synthesis. PTU also offers the benefit of blocking the peripheral conversion of tetraiodothyronine, or T4, to triiodothyronine, or T3. To manage the systemic, T3-mediated effects, particularly cardiovascular symptoms, beta-adrenergic blockers are crucial. Propranolol is often used, typically at 60 to 80 milligrams orally every 4 hours. For patients who cannot tolerate oral intake or require strict rate control, an esmolol infusion may be used as an alternative. Additional interventions. Once antithyroid drugs are started to block new hormone synthesis, the release of preformed hormone must be inhibited. This is achieved using stable iodide preparations, such as potassium iodide. The standard dose is 5 drops, which is approximately 0.25 milliliters or 250 milligrams, given orally every 6 hours. It is critical that this is administered 1 hour after the first dose of the antithyroid drug to prevent the iodide from being incorporated into new hormone synthesis. Glucocorticoids are another core component of therapy aimed at supporting adrenal function, decreasing peripheral T4 to T3 conversion, and treating possible relative adrenal insufficiency. Hydrocortisone is given as an intravenous loading dose of 300 milligrams, followed by 100 milligrams every 8 hours. An alternative is 8 milligrams per day of intravenous dexamethasone. Fever and hyperthermia require management with antipyretics. Acetaminophen, 500 milligrams orally every 8 hours, is the recommended agent. Other antipyretics, such as nonsteroidal anti-inflammatory drugs, should be avoided due to potential inhibition of protein binding of thyroid hormone. Adjunctive and second-line treatments. Several other treatments are available to bind and eliminate circulating thyroid hormones or block their release. Cholestyramine, a bile acid sequestrant, can bind thyroid hormone in the gut and is given at 4 grams every 6 to 8 hours. This must be administered 1 hour before or 4 to 6 hours after the antithyroid drugs. Lithium carbonate, 300 milligrams orally every 6 hours, is an option to inhibit hormone secretion, particularly if iodide preparations are contraindicated. Potassium perchlorate at 200 to 1,000 milligrams orally daily is used primarily in cases of amiodarone-induced thyrotoxicosis type 1 to block iodide uptake by the thyroid gland. These adjunctive therapies are indicated in specific situations. They are considered when severe symptoms persist and no significant clinical improvement is observed after 24 to 48 hours of first-line therapy. They are also used in cases where there is a contraindication or toxicity to the primary agents in amiodarone-induced thyrotoxicosis type 1 or as a necessary bridge to definitive treatment, such as thyroidectomy. Plasmapheresis. For cases that are refractory to standard medical treatment or are immediately life-threatening, therapeutic plasmapheresis may be necessary. This procedure physically removes circulating thyroid hormones and antibodies. Treatment is continued until clinical improvement is achieved, which typically involves 3 to 6 sessions. Definitive cure. Once the patient is stabilized and the acute crisis has been managed, definitive cure is addressed. This involves eliminating the source of excess hormone production through radioactive iodine ablation or surgical thyroidectomy. These definitive measures are typically planned after the patient's condition has been optimized.